Dear friends, welcome back to the show Talk with Your Doc, and we have Dr. Graeme Marchuk here. We're talking about different surgical options available for the brain tumors. Dr. Marchuk, please tell us what is this gamma knife therapy?
Yeah, so excuse me, a gamma knife is a machine. It's kind of like an MRI scan. You can conceptualize it as an MRI, but it's not an imaging device per se. It's a treatment device, and it allows a combination of doctors, a radiation therapist, usually a neurosurgeon, and a physicist and an oncologist to get together and to deliver focused radiation to a very specific area of the brain or a very specific pathology. Mm-hmm. So what it entails is the uncomfortable part of the procedure is the patient has to have a metallic frame bolted to the head. Mm-hmm. And so that's done under local anesthetic, freezing the sites where the pins for the frame go. And so that's done, say, on the morning of your procedure. And then you go for an MRI scan. And then the doctors use that information to localize the pathology they want to treat, say a metastatic tumor to the brain that's small, but in an area that the surgeon doesn't feel like they want to resect. Okay. And then the patient would then lie in the machine in the frame. They actually bring some music with them that they can listen to, their own CDs and that sort of thing. And then they get radiation treatment. And the radiation, we often describe it to people kind of like taking a magnifying glass in the sun and mm-hmm. focusing that beam down so that you can burn a hole in the wood. It's a similar idea. The radiation beams are concentrated to that site. Right. It's painless apart from the frame, and then the frame comes off, and then the patient returns home.
So gamma knife is used when there is difficult to resect the tumor, and then we use this gamma rays to burn the tumor. Is that what we do?
Yeah. So you're delivering radiation is a common treatment for many types of tumors. So often, say the most aggressive type of adult tumor we'll see is a glioblastoma.
Glioblastoma.
Right. So that's a WHO or World Health Organization grade 4 tumor. And so often radiation is part of the whole therapeutic picture. Right. But usually those growths are large enough that they need to be treated surgically first, and then more of a field radiation is delivered to the area. Right. Gamma knife tends to be reserved for smaller tumors, in particular cerebral metastases, metastatic tumors spread from the lungs or other parts of the body, because sometimes there'll be several of those, and so the gamma knife surgeons are able to target each of those in the same setting, deliver little focused areas of radiation to each lesion.
So once a patient is treated with a surgery for benign or malignant tumor, are there any other additional treatments like chemotherapy or radiotherapy they have to undergo? Yeah,
it depends on the type. So certainly for the more aggressive tumors, almost all of those patients it will be recommended that they receive radiation. And a common approach to cerebral metastases now, if the tumor is large enough and in an area that we think that it's safe to resect, we'll take the tumor out. Mm-hmm. And then it's becoming more and more popular to actually send that patient for gamma knife and have the tumor bed treated to lessen the chance that there'll be any spread from that area of any sort of residual cellular tissue. And then oral chemotherapy is often used in the more aggressive gliomas. Yeah.
Right. Now, once the patient has been treated with surgery followed by chemo or radiation, what is the lifestyle like? Does patient become normal, or do you have to follow up with the doctors regularly, and what are the precautions they have to take?
There's definitely still some ongoing follow-up, particularly with members of the cancer care team. So there'll be ongoing MRI studies of the brain to watch for recurrence. And then in terms of how the patient feels, there's often some initial sickness from the radiation treatments mm-hmm. that can drain your energy and give you headaches and make you feel unwell. Right. The chemotherapy is fairly well tolerated, fortunately. Mm-hmm. But in terms of the return to normalcy, it depends a lot on the initial presentation, if the patient was neurologically impaired mm-hmm. when they came in, were we able to restore that neurological function as a result of the treatments? Or were there even some consequences of the treatments, like the surgery could lead to a complication that could then lead to diminished function, like difficulty speaking or weakness or something that they have to accommodate to.
Right. So then they have to undergo like a multi-specialty care, probably cognitive therapy, physiotherapy, rehabilitation therapy, like that?
Exactly. It depends on how well you are. I have a spectrum of what I've seen to patients that I've done an operation on the brain for a tumor and sent them home mm-hmm. in 2 days with none of those extra services while we're waiting for the pathological data to come back, to people that require additional physiotherapy, occupational therapy, speech therapy, neurocognitive therapy, as you mentioned, and so often those patients will spend some extra time in hospital.
Yeah. Those help to patient to come back to the normal life.
That's right. That's the goal. That's always the goal.
Now, can a patient get pregnant after the brain tumor?
Yeah, that can be done. It can be done. Yeah, and certainly with the benign tumors, it wouldn't be an issue. While they're undergoing treatments, I think that would be recommended not to. Right. And then you always have to think about when your follow-up imaging studies are going to be, because there would be a reluctance to do any MR imaging while you're in the pregnancy stages.
Now, what is the typical duration of the treatment once the patient has been diagnosed with a tumor on the on the CT scan or MRI? How long it takes to get the whole course of treatment done?
Right, so we usually see those patients quite quickly. They're often referred through the emergency department, but sometimes not, and through the outpatient neurosurgical clinic. So we'll see those patients very quickly. The goal is to get them into the operating room to get their biopsy or their resection within a week or two, so quite quickly. And then usually the radiation and chemotherapeutic treatments start right away, and that could be thought of about maybe about a 6 week total.
6 weeks. That includes the radiation.
Yeah, total duration. The radiation treatments don't take too long, and then the chemotherapy might continue for a while after that. Depends a bit on what the follow-up MRI scan shows.
Now, what is the chance that tumor will come back?
Yeah, so it depends again on the type. So with the benign ones, like I said, if they're resected, there is a very good chance that type of tumor will never return. The sort of lower grade tumors that we might biopsy, we might then watch those for a long time or deliver some radiation and then just monitor them. And they might, change with time, but they might take years. The more aggressive WHO grade 4 tumors, unfortunately, they can come back quite quickly.
So the prognosis of this tumor, like grade 4 tumor, glioblastoma, is really, really bad, or it varies with the age groups?
It varies with the I tell patients it varies with the biology of the disease.
Okay.
So how it responds to the chemotherapy and the radiation that we give, how much we're able to take out during surgery. Are we able to get all of it out versus just taking part of it out because of the anatomy of how it's developed?
Right.
Yeah, so it's very dependent on those things. I have some patients, as I mentioned to you earlier, that are 7 years out from their treatment without any recurrence, but we have others that succumb in a matter of months.
Yes. Now, once the patient has been diagnosed, treated, what sort of follow-up investigations are required?
Yeah, so those patients will usually be followed up in the cancer clinic afterwards. So repetitive MRI scans with dye, and that may be done initially at fairly short intervals, so say at 3 months, and then maybe another 3 months, then maybe 6 months if it's stable. We'll watch somebody with a malignant tumor quite closely because we just know it has this potential to come back. More benign things, if I take a meningioma out and it was a benign WHO grade 1 tumor, I might do some MRI scans for a few years, but then push the follow-up out for several years.
So follow-up is very important. Even though it might be benign, it can turn into something bad.
I think it's important for patients to continue to be followed.
So once you're treated does not mean that you are out of the loop. You have to go to the doctor and get your disease tested.
Yeah, I mean, it depends on the specific type and what your specialist tells you, but my tendency is to try to continue to follow people, just because we've all seen strange things happen, and we've all seen late recurrences, and so it's just wise, I think, to continue to follow these patients.
Thank you, Dr. Marchuk. Thank you for coming today and giving us so much information about the brain tumors. Really appreciate it.
You're welcome.
Thank you, viewers, for watching the show Talk with Your Doc.